So our next speaker in the section on consensus on controversies is Dr. Padmaja Sudhakar, who's a senior consultant in UK healthcare doing specialty work in multiple sclerosis, neuroimmunology, neuro-ophthalmology, and neurology at her Advanced Eye Care Center. She's going to be talking to us on how has the management of optic neuritis changed over time. A very important topic, and we look forward to hearing from you.
Good evening. I thank the organizers for inviting me. So, optic neuritis, we all know, is inflammation of the optic nerve. It comes from multiple etiologies depending on which the visual prognosis and the recurrences vary. If you ask the one question, has the management of optic neuritis changed? Yes, because today we have these new pathological glial antibodies. That's your aquaporin IgG4 antibody, the MOG antibody, and the glial fibrillary acidic protein antibody. Today, optic nerve during the inflammation can be used to rapidly identify disease-relevant autoimmune targets, deliver timely therapeutics to improve visual outcome, and determine future neurologic disability. The first step is we need to know the difference between typical and atypical optic neuritis. Typical optic neuritis is the one associated with MS. Atypical requires the testing for the new pathological antibodies. Distinguishing the two at initial presentation is very hard, but they have very distinct clinical and radiological features with different outcomes, so they require slightly different treatment. So what are the red flags for your atypical optic neuritis? Someone with a severe visual impairment less than 2400, think about NMO and MOG, because typical optic neuritis is usually 2200 or better. Bilateral optic neuritis is more common in children, MOG and NMO. The ONTT taught us that 95% had unilateral vision loss in their series of typical optic neuritis. Recurrent optic neuritis is another red flag. Poor visual recovery. If you don't see at least one line of visual improvement within 3 weeks of onset, that case could be atypical. Prominent disc edema, idiopathic optic neuritis or typical optic neuritis, less than 25% have disc edema. So if you see significant disc inflammation, hemorrhages, ocular inflammation, think infection, think MOG. And then signs of area postrema syndrome with nausea, vomiting, and hiccups, think about NMO. MRI can give you a lot of clues. So if you have a bilateral optic neuritis, which is longitudinally extensive, involving both extensive retrobulbar optic nerves, that can be NMO or MOG, usually MOG. If you have more than 50% of the retrobulbar optic nerve involvement, more posterior involvement of the optic chiasm or the tract, think about NMO. If you have a perineural teeth enhancement and orbital fat stranding, that can be MOG. But preneuritis, you also have to think about syphilis, and of course in India you have to think about TB. The MRI can give you other clues. It can pick up your MS lesions. Similarly, you can have lesions in the spinal cord. But if you see lesions in the pre-ependymal location in the fornix and hypothalamus, think about NMO. A longitudinally extensive lesion in the spinal cord, we all know that we have to think about NMO or MOG. But remember that MOG involves the lower cord and the corners. Similarly, you do not see inflammation of meninges in your demyelinating optic neuritis. So that will suggest granulomatous disease or infection. CSF can give you clues. A mild pyocytosis with less than 56 can be, less than 50 cells could be your typical optic neuritis. If you have more than 100 cells, think about MOG. If you see eosinophils and pigments in the CSF, that would be NMO. And oligoclonal bands, very typical for MS. So how do we treat? The ONTT taught us that IV methylprednisolone for 3 days followed by oral prednisone for 11 days accelerated visual recovery in optic neuritis but failed to improve final visual outcomes. Even today, we treat optic neuritis with IV methylprednisolone, but we give a gram daily for 3 to 5 days. And then subsequent study shows that a corticosteroid equivalent 1000 milligrams IV methylprednisolone can also give accelerated recovery. In fact, they've even used intramuscular or subcutaneous ACTH. Oral prednisone is a no-no in typical optic neuritis because it increases your relapse. But if you have sarcoid optic neuritis or cryon, you can use low-dose oral prednisone. Similarly, ONTT taught us that IV methylprednisolone delayed conversion to MS in the first 2 years. But when the study participants were reclassified, this was not true. Similarly, it did not even reduce the relapse rates as was originally thought. So what happens when you have optic neuritis refractory to steroids? Then you go for IV immunoglobulin or plasma exchange. Now, IVIG did not improve visual outcome according to some studies, but plasma exchange can improve visual outcome in corticosteroid refractory optic neuritis or optic neuritis associated with NMO, with increased response seen in male sex, those with lower baseline disability, and where there's a rapid initiation of treatment. If you have an NMO patient where you know you're going to have poor visual recovery and recurrent optic neuritis, go for plasma exchange straight away as the first line treatment. We usually give 5 sessions. And if you have optic neuritis which has failed methylprednisolone in the past, or it's a recurrent optic neuritis of NMO and MOG, you can even do a combination of methylprednisolone and plasma exchange. And finally, make an attempt to diagnose your MS, NMO, or MOG. Because once you know it, you know that you have to give them long-term immune suppression. So they have to be now managed by a neuroimmunologist or a neurologist. So in conclusion, if you have typical optic neuritis, this is self-limited with a strong chance of recovery. But atypical, you can have more severe vision loss and they can recur without prophylactic treatment. Clinicians must differentiate the two. You must give aggressive anti-inflammatory therapy and targeted immune suppression to minimize short and long-term visual loss from optic neuritis. And I thank you.
Thank you very much, Dr. Padmaja. That was a very succinct talk. A question to Dr. Pradeep Sharma or Dr. Rohit. Is multiple sclerosis a less common cause of optic neuritis in India compared to West, or?
So I would say it otherwise. I would say that proportionately, NMO is a higher percentage-wise in Indian population as compared to the West. So studies from Lekhi Pandit from Mangalore have shown that up to 20% of optic neuritis would be NMO positive, which is definitely higher than what has been reported from the West. But I would say that, I mean, that's why I would say, and the other thing, of course, we have a lot of infectious causes, which are very important. So proportionately, optic neuritis due to MS may be proportionately less as compared to the West because the other factors are significantly important in our circumstance. Sir.
Murli, any questions before you go on to our next speaker?
Yeah, I have a question for Dr. Ambika, and I mean, anybody can answer. So considering that doing anti-MOG and anti-NMO in every case considerably adds on to the cost because we have to get the cell-based assays done, is it possible to guide these investigations radiologically, at least in the Indian scenario, as to what you would do? Like if the MRI is very typical of MS, maybe you could, you need not do these two. Any thoughts?
I think that's correct. I mean, but we're much better now at diagnosing MS on MRI because of the more precise criteria over the characteristics of the lesions next to the peel surface, following venules and so on. We've got many more criteria now, and I think if you do make an accurate diagnosis of MS on imaging, there is no need to do the other tests, unless there's something else unusual about it. We have some overlap cases that look like MS and have NMO antibodies, but they're relatively unusual. I've always been unhappy with the terms typical and atypical for the reasons that you're talking about now, because it depends the age of the patient, the gender of the patient, and where you are in the world, what's typical. In Thailand, MS is something like 5% of optic neuritis. we're actually just introducing trying to introduce a new optic neuritis classification which takes this into account, and it means that people will call, if you use it, rather than talking about atypical, typical, you either talk about idiopathic, you don't know the cause, or you give the cause. It's MS, it's NMO, it's MOG, whatever you've found. And I think that's it's a lot safer to do that.
Thank you very